This Paediatric Parent Feeding webinar has been created by the North East London Foundation Trust Redbridge Feeding Team and will focus on what are feeding difficulties and how can parents help. Firstly, introducing the Redbridge Feeding Team. This is typically made up of our speech and language therapists who have specialty training in feeding and dysphagia, and we are well supported by our multidisciplinary team, which includes paediatricians, occupational therapists, dietitians, physiotherapists, and other speech and language therapists focusing on communication. The purpose of this webinar is to increase your understanding of feeding challenges and their perseverating causes, to identify your child's specific feeding needs, to help set up positive mealtime routines, and to increase parental confidence in feeding and food introduction. Firstly, we're going to introduce some myths that surround feeding. The first myth that we often hear is that eating is the body's first priority. This is actually not true. The body's first priority is breathing, and the second priority is keeping our head steady in space. Feeding comes along further down the list. The second myth is that eating is instinctive. It is not an instinctive practice, and it takes learning. Reflexive eating and feeding only takes place when a child is very, very young. Number 3, that eating is easy. We know that eating or feeding is one of the most complex organizations that happens within the human body. It encompasses all of our systems and all of our organs, and is by no means an easy thing to do. Number 4, that eating is a 2-step process. The first step being to sit and the second step being to eat. Again, this is not factual. There are many, many steps involved with eating, and we will talk about that further. Number 5, that it's not appropriate to play with your food. Again, we say that this is a myth because this is how children learn about food. Touching food, being messy with food is all very important. The 6th myth that we will hear about often is that a child will not starve themselves. Again, we know this not to be true. Children can bring themselves into a state of malnutrition if they experience feeding and eating issues. Number 7, that children only need to eat 3 times per day. Again, children are all different and they require different volumes of food, different timings around food, and this does not necessarily dictate 3 set meals. Number 8, if a child doesn't eat, they have a behavioural or an organic problem. Again, this is not true. There are many, many reasons why a child may experience feeding issues, and it's important that you collaborate with your feeding specialist or your medical team to work out what those issues might be. Number 9, that certain foods should only be eaten at certain times. This is a societal construct. It is fine to eat breakfast foods at dinner, and it's fine to have dinner foods at breakfast. We know that if a child's going to eat better in the morning, perhaps we should offer our most challenging foods then. And number 10, that meal times are a proper social occasion and that we should always use our manners. Again, we want to focus on our feeding skills and our eating behaviours first. Manners can come along further down the track. Now, as a feeding specialist, we have 3 overarching categories on how we classify a feeding problem. The first problem that we are looking out for are swallowing problems, or what we clinically describe as dysphagia. Now, this might be when a child is not swallowing their food in the ideal way, and there's a possible risk of that food going into the airway. The second concern that we have is challenges in our oromotor skills, or underdeveloped chewing, or inability to progress in our textures. And the third category that we look for is food aversion, or any sensory or behavioural issues that we might experience. The second 2 categories are what we will be mostly talking about today. Now, here is a diagram representing how feeding is holistic. Now, this is supposed to be an iceberg, and we can see poking out of the top there is feeding as an overarching category. But of course, we know, like an iceberg, there are many, many things that go on under the surface. Now, feeding is a very complex thing to do, and it's actually very challenging for our bodies to organise this process. It encompasses all of our organs, all of our muscles, both inside and out, all of our 8 senses, and this includes proprioception, smell, taste, touch, and of course our visuals and our hearing. Then we have the learning history of that particular feeder. What's their style of learn, what's their capacity to learn. We also have the concept of their development. Are they typically developing? Do they have a difference in their development we need to take into consideration? We then talk about the nutritional status of that feeder. Are they receiving adequate nutrition? Have they got a history of not having adequate nutrition or not being able to access that? And then finally, we also talk about the environment. What environment is this feeder working within? Is this changed? Is this different? We're now going to touch on what are the steps to eating. So we spoke before about there being more than 2 steps, more than sitting, more than eating. There are actually 32 steps, and they are all very important. Here we can see the 32 steps broken up into a diagram. Now, to sort of break them down into a more simplistic term, we break them into the first step being to tolerate, the second step to being interact with, the third step being smell, the next step being touch, then moving on to taste, and then of course finally to eating. Now, within all of these steps, it's broken down into much smaller steps, which is really handy because it can help highlight the progress that your child might be making towards our ultimate goal of eating, but show that we have in fact made progress without interacting or progress towards food. So at the bottom we talk about someone being able to tolerate. A good example that I like to use with parents is imagining that there is a jar of poison. Now, if we use the jar of poison as a representation for food, we can start to understand how our children who have aversive issues feel about new food items. Now, if I asked you where would you like the poison in the room, your first thought might be actually I'd like it outside the room. I'm not going to enjoy the poison being in the room at all. But if I then asked you to say, let's bring the poison a little bit closer, where would you have it? You might say, well, it can come inside the room, but it has to be as far away as possible on the other side of the room. And then you might tolerate it being brought a tiny bit closer to the table, but perhaps on the other side of the table. And then you might tolerate it being brought halfway across the table. And then maybe bring closer to your plate, not on your plate, just off your plate. And then you might be able to tolerate it being on your plate, but of course, you're not quite up to interacting with it yet. And then of course, when we're looking at interacting, if we ask you, you might tolerate touching it with some utensils or with a napkin. You might be able to pour it onto something else or serve it to another person. You might then be able to use the fork to engage with it. And once you've moved through all the steps of interaction, you might then be ready to smell that food. And again, you might be able to tolerate the food being open, or the poison, as for example, being open from the container, so we can tolerate it in the room. You might then be able to tolerate it being closer to you on the table, within your space, and then you might even be able to lean down to smell it. Then we move through to touch. If you're going to touch this really horrible thing or this poison that you don't want to, you might touch it with your fingertip, then a couple of fingers, and then you might have it on your whole hand. You might tolerate it on your arm, then your shoulder, then to the top of your head, your chin or cheek, up towards your nose. Then you might touch it to your lips, your teeth, and your tip of your tongue. And once you've moved through all the steps and being able to touch a food, you might then move to taste. So you might be able to touch it just to the tip of your tongue, then perhaps give it a full tongue lick, then maybe bite off a piece and spit it out, maybe bite a piece, chew it, or hold it in your mouth for a couple of seconds and then spit it out, bite a piece, chew it a couple of times and then spit it out. And then of course you move to eating. And even that doesn't go straight to eating and swallowing. You might bite and chew, swallow a little bit and then spit some out. And then of course you might get to our ultimate goal of chewing and swallowing the whole mouthful independently. So as you can see, there are many, many, many steps involved with eating, and it's not a very simple process. And for our children who experience aversion or are very worried about trying new foods, there are lots of steps that they can work for before getting to our ultimate goal of eating. So this is an important thing to keep in mind, and also to understand that your child may make progress with food before being able to eat that. Now we're going to talk briefly about chewing. So chewing is the process of grinding or mashing foods so that it becomes a safe consistency to swallow. And it's what we call the oral phase of swallowing. So what happens when we don't chew a food properly? Well, we are at risk of safety concerns, like possible choking. It might hurt when we go to swallow because the pieces might be a bit large. It could cause our child to have a fear response if they haven't chewed their food properly and maybe not want to interact with that food again. And the difference between chewing or oral motor difficulties versus aversion to food is that oral motor difficulties are a motor-based mechanical issue, where an aversion is a child's fear or worry about interacting with a new food. So let's think about some of the reasons why a child might not be chewing. It could be that they haven't developed that skill yet, they haven't had exposure to foods that require chewing. It could be that they have some difference in their development, which means that they aren't able to coordinate their muscles appropriately and need some intervention. It could be that they have such an aversion to texture that they're not willing to put anything that requires chewing in their mouth. So sometimes aversion and our chewing difficulties can actually play together. There are lots of stages of chewing, and we'll work through these really quickly, but again, it just goes to show that it is not a process of simply putting a food in our mouth and chewing away. First, we need to start with even a coordination of a suck, swallow, breathe pattern, which is what we see that our really, really little infants do when they're feeding. Then we need steady head control to be able to ensure that we're staying upright whilst we're managing any new textures. We then need some reflexive sucking, which is replaced by learned motor patterns. So instead of us reflexively feeding, whether that's on a bottle or a breast, we start to actively suck and participate in that routine. And then we start beginning our hand-to-mouth play, or our independent exploration of objects. This is really important because if a child is not engaging or playing with items that are around them, they're not going to be able to participate in any self-feeding. We then need to move towards trunk control sufficient for independent sitting greater for 3 to 5 minutes. This tends to start happening around when a child is about 4 to 6 months of age. We then need stable head control and sitting, so no consistent bobbing. Again, important for when we're engaging our child in feeding for the first time, or oral feeding for solid foods for the first time. We then move to the next stage, which is where we see what we call tongue lateralization, which is basically the clinical term for moving our tongue side to side. We then start to see some munching or some gnawing, which is not the adult chewing or the rotary chewing that we start to see, but very simple up and down motions. And then we start to see even better lip control, which supports the movement of food back for a swallow, so everything isn't falling out the front of our mouth. On the next stage, we start to see active tongue lateralization, so that moving side to side, we're becoming more control of that. We then have our rotary chewing, again, that more adult descriptive chewing where we're moving our food around, we're pushing it side to side, we're identifying any lumps. And we then also see a change in our taste bud perception, which is why we're able to engage with more food items with stronger flavors or more different flavors. We then see our children become efficient finger feeders at this point. So they're picking up food, they're placing it in their mouth independently, using all of these good lateralization and rotary chewing skills. And then we start practicing our utensil use, and we use that for obviously foods that require utensil use, or we can use it for more effective volume. And then finally, we have all our oral motor skills hopefully needed to engage with any table food that's presented, and our increase in our utensil use. And to keep in mind that we don't usually see this very efficiently until a child's about 2 years of age. We're now going to talk briefly about the food stages that we tend to describe when looking at feeding a child or a baby. The first stage we would usually introduce to our babies is stage 1, or purees. So purees are even broken up further into stage 1, stage 2, and stage 3. This basically dictates the smoothness or lumpiness of those textures. So some examples of purees might be applesauce, our shop-bought baby foods, or a yogurt. We then move on typically to stage 2 foods, which are our meltable hard solids. So when we say meltable, this means that if we put a food into our mouth, for example something like a baby rusk or a What's-It crisp, that they start to melt when our saliva touches them. So these foods are a really good first mechanical or chewing food that we give to our children, because whilst it requires that early lateralization and munching motion, the nature of the melting factor means that they're much safer, and that, you know, even without adequate chewing, they will be safe to swallow and essentially turn into purees. We then introduce stage 3 foods, or soft cubes. So these are things like boiled vegetables like potato or carrot, also things like avocado or banana are soft cubes. Again, really good because when a child is developing those lateralization and rotary chewing skills, the munching will effectively break these down so they're safe to swallow. We then tend to move on to soft mechanical foods. So these are single texture foods, so not mixed textures. We're not adding sauces and extra different pieces to things. We're keeping them very consistent. These are things like a soft muffin, some fruit bread, or some soft pasta. These require slightly more developed chewing skills, but again, safe for our young kids and babies. We then move to stage 5, which are our soft mechanical foods, and these are mixed textured foods. So these things like chicken nuggets, macaroni and cheese, and spaghetti. And then finally, the most challenging food that we will introduce would be a stage 6 food or a hard mechanical. And these are things like crunchy crackers, cookies, fruit sticks with peels, things like carrot sticks, because again, they're very, very challenging for us to chew, require a lot of mature chewing skills. Now, it's important that whilst we're able to introduce lots of different textures, that we ensure that a child has mastered one stage before offering them something more complex. If we're finding that a child is maybe experiencing difficulties at stage 5, we might leave them there a little bit longer until they get a good control of those foods until we introduce the hard mechanicals. Because of course, these do pose an increased choking risk if a child has not developed the adequate chewing skills. And to break this down even further, we kind of look at, with a typically developing child, we might introduce some of these stage 1s or purees around 6 months and expect that over the next 6 months, they might move towards some of these more challenging family type meals. So this is in a sort of typical weaning pattern that we would see them start with runny purees, moving to thicker purees or mashed food, going to those hard munchables and bite and dissolve snacks again, and then those soft finger foods or finger solids down to those mixed textures, which are the most complex. So some ideas that you could think about if you've got a child who maybe is eating mashed potato quite well, you could look at strips of well-cooked boiled potato as a new example. If you have a child who's managing fruit purees really well, you could do some strips of a peeled ripe pear. That would be a good example of a soft sort of cube. You could, if they're having sponge cake and custard, you could try the cake given dry in fingers, and the custard could be diluted and drunk or used as a dip. We're now going to talk about creating a calm feeding environment. So firstly, what does a calm feeding environment look like? I think the important thing to highlight here is that it is going to be different for every home and every setting. But ideally, around mealtimes, we aim for reduced noise and reduced distractions, for appropriate sitting and positioning for that child's skills and needs. We like to make sure that the adults who are present are calm and able to support that learning, particularly around new foods. The expectation around new foods is to learn about them and not necessarily eat them. We want to avoid force feeding and definitely avoid bribing as well. And we want to provide the child with skills to communicate when they feel worried about food and acknowledge these feelings. So here's some examples that one size doesn't fit all when we're looking at our feeding environments. Sometimes it might be a single parent feeding a child in a high chair. It might be a family sitting at a table where there's multiple children being fed at the same time. Your family might not typically sit at the table, you might sit together on the floor. All of this is fine. It's about finding what works best for your family and focusing on that calm, regulated, consistent environment. We're now going to talk briefly about posture and positioning when feeding. So we can see here that this child is sitting at what we like to describe as a 90-90-90 seating position. The child's feet are flat on the floor, their knees are bent at 90 degrees, and their back is upright at 90 degrees. Now, this is important for when we're eating because as we spoke about in our myths around feeding not being the first body's priority, that keeping our head upright in space is one of the body's first priorities. So if our body is all over the place, if we're not feeling secure, we're not going to be able to access a meal most appropriately. So considering our positioning is very important. And we also want to make sure that any time whether we're feeding a child or having a meal with a child, that they're facing the adults so they can learn from us, engage with us, and also be exposed to the social constraints that we expect around meal times. So going back to our food aversion, what are some solutions that we will recommend around our kids who are quite aversive or worried or avoidant of foods? The biggest one that we recommend is messy play. Now, usually this is organised in its setup. It is an activity that we would do, especially with our child. We wouldn't necessarily just sit them in an area with lots of different food items. We want to make sure that we're using child-friendly language. We want to make sure that ourselves that we're not worried about the mess. We can always clean it up at the end. We need to have a focus on making it fun and enjoyable, and we need to consider those 32 steps to eating that we talked about before. Now, here's an example of a very sweet child who looks quite overwhelmed by the amount of pasta that they've gotten all over themselves. Again, if this is how your child is going to learn about a new food, that's okay. We can encourage them to engage and eat with that food. But to the right, we've got an example of what messy play might look like if you have a child who's not quite at the phase of putting it all over themselves or eating it. We can run some of their preferred toys through these new foods. We can teach them to squash. Again, gauging through those 32 steps to eating, starting right down with our tolerating, up to our interacting, going up to our smell and our touch, and then working through those steps as appropriate. And now we're just going to talk about some general management strategies or recommendations that we have for children who might be presenting with some feeding issues. The first is social modelling. The child is not the focus, but modelling good eating behaviour is. We want to talk about the food, we want to describe the food, we want to make meal times positive. And we definitely want to avoid yelling, pressure, or bribing the child throughout meal times. Again, this comes back to making meal times positive and modelling those good eating behaviours. The next, we want to talk about structured meals and snacks. We would like to aim for our meals to be no longer than 30 minutes. The reason that we suggest this is that a child's tolerance for sitting and engaging doesn't usually exceed this. Also, our hunger signals start to shut off around 20 minutes after eating, so it's important that we try to keep to around 30 minutes per meal. Throughout the day, we would aim to offer 3 meals and 2 snacks, and we would like to offer a range of textures and tastes throughout the day. We then talk about reinforcement. So we want to use that "you can" language with lots of positive praise. So instead of asking a child if they want to eat something, you might recommend "you can eat something." This gives them permission and avoids offering them the option to just flat out refuse no. So try using our "you can" language instead of "do you want to" language. And then explain at a child's level. So we want to make sure that the child's understanding what we're talking about. If you've got an older child who's maybe nervous or is learning about a food, we can talk about our teeth mashing up food, or we could describe a new food as a way that we're learning about that food, that we don't have to eat that food. We're now going to talk briefly about a dietitian's role in feeding. So as we discussed, the feeding team is usually led by speech and language therapists who have specialty qualifications in feeding and dysphagia. We work very collaboratively with our dietitians who work to support the child's nutritional needs in order to support development and growth. And the dietitian becomes involved when a child is not meeting their nutritional needs or does not meet weight and height expectations. If you're known to the feeding team and the speech and language therapist has concerns, you might find that they'll refer you to the dietitian to get some extra input. So that's quite a lot of information, and what do we do now? So what we recommend is that you implement some of the recommendations around routines, messy play, the steps to eating over the next 6 to 8 weeks, as we would expect some nice progress in that time. If you fail to see any progress in your child, or if other concerns arise, particularly around safety or skill development, please contact the feeding team for some more support. And do remember that feeding issues are complex and they take time to address, and that any progress should be celebrated. So we'll leave you there, and as always, if you need any more support, please contact the Redbridge feeding team. Thank you.